All right, how are those smoothies? Were they good? They were excellent. All right, we'd like to remind you to open your Has app to session 40 for this next speaker. And I'd like to introduce the speaker, and he told me I had to make it really, really short. So, our next speaker, Dr. John Halamka, is the Chief Information Officer at Beth Israel Deaconess System, and he said he likes to be known more as the Chief Engineer and Farmer. Please join me in welcome Dr. John Halamka.
Wow. So I've been given this awesome responsibility, Paul, of sending these folks home with summarizing everything new in digital data and analytics around the world. This is a difficult challenge, but hopefully I can do it. So as he said, I travel 400,000 miles a year, going country to country, trying to understand trends in digital health, look at what works and what doesn't work. Often I'll end up in a country and they'll say, we'll just do a meaningful use program. How about that? And I say, maybe not. So I thought it would be good to take you around the world, country by country, and take a look at what's happening in digital health, why each country has an urgency to change, and how digital health and analytics is fundamentally going to change the way we deliver care. So let's start with China. I'll actually be in Shanghai this weekend because China has recognized it is not going to be able to sustain its healthcare system, its aging population, its lack of doctors, unless it becomes more digital and data-centric. So this is the waiting room at 7:30 in the morning at Huashan Hospital. Think of Huashan as an academic medical center affiliated with Fudan University. Now, was there a mass casualty disaster? Was there an epidemic? No, this is 7:30 on a Monday. Now, why? Well, the derm clinic at Huashan sees 4,000 outpatient visits a day. Why? There is no primary care in China. So let's see. I woke up this morning. You see this little brown spot there? Could that be cancer? I know. Let me go stand in line at an academic medical center to see a very famous dermatologist. And this is what happens. So you have a lack of triage, and you end up with the wrong patients in the wrong setting, seeing the wrong clinician. So what does China want to do? Well, first thing is that we better codify the data. So it turns out in China, there's traditional Chinese medicine. There's no vocabulary for that. So we'll work on taking the various components of the medical record, and like we've done in the US and other countries, use appropriate vocabularies, SNOMED CT, LOINC RX norm, bring them together in a standard data set, and then we'll create the standardized data set for China. Now, there is a slight difference between the Chinese government and the US government. Do you remember the stimulus program? Well, the stimulus program in China is pretty simple. You want to keep working in your hospital? Send us your data. And so it's going to be a very, I think, scalable and easy to accomplish at a short time scale kind of effort. And what are we going to do with all that data? Well, imagine this. You have patients and families that need to navigate a healthcare system. If you pull out your phone, say, I have these signs and symptoms. How about looking at the other million people in my neighborhood that have those signs and symptoms and how they got care and what worked, what didn't? And then say, oh, well, here are 3 places you could go in your local community that can address those signs and symptoms, and here's the sort of thing that it might be. So this is the kind of tool I can imagine not only would be useful in China, but even just think about us. I'm guessing, looking at the group, that sometimes you are asked to arrange referrals to doctors for your family members or friends. How hard is that? It's like, I don't know who to send you to. Well, let me tell you a little bit about why this is hard generally, and I'm going to use a very strange personal example from last night. I have to really thank the Health Catalyst team. They're just amazing people. Here's what happened last night. We went to a lovely restaurant. I had a typical vegan meal, as I always do. I was chatting with various folks from Asia Pacific and Germany about the trends in their countries. I stood up and fell to the ground unconscious. Now, I was looking for some new experiences in Salt Lake City, but unconsciousness was not one of them, and alcohol was not involved, I swear. So how do we take that set of events, looking at digital data and analytics, and ask, well, what should you have done for me next? Well, my friends at Health Catalyst didn't realize that I happened to be wearing a continuous ECG monitor. Now, there is a slight design flaw. You have to actually push this button to start the recording. When you're unconscious, it doesn't work so well. But afterwards, I was able to see that I was in a normal sinus rhythm at a rate of 55. Certainly, this was not a VT or other issue. Paramedics were called. I had a BP of 110/70, completely normal. And I had a fingerstick glucose. Fingerstick glucose was 90, completely fine. But here's where it gets complicated. If any of you are from Massachusetts, you may know that we have a crisis with EEE and West Nile virus right now. And I just so happen to operate a farm in a wetland in the center of the crisis area. And 48 hours ago, I was moving corral panels at dusk and was bitten by many mosquitoes. Okay, so I've just passed out on the floor. Is this West Nile? Is this EEE? Is it a syncopal episode? Is it a seizure? This is, again, it's a tough kind of question to answer, but if you imagine, as we collect data, and that data is medical record data, telemetry data, you can say, well, probability is, and in this case, it was a syncopal episode. The one bit of data I didn't give you is the temperature, and that is paramedics did a tympanic measurement. My temperature was 102. And I don't really have a locus of infection, but maybe a little bit of GI symptoms. So my primary care doctor and I, this morning, went through all the data, and here's what we concluded. I had a viral gastroenteritis, which caused all the fluid in my body to go to my abdomen. I had a meal which caused a vagal stimulus, and then all of the blood that was going to my brain went into my intestines. I stood up, and I had a vagal episode. I was not postictal or incontinent. It was not a seizure. And we looked at the telemetry from my watch and determined it was not a cardiac event or arrhythmia. So I tell you all that because this is the kind of healthcare system we all want. Being able to gather data in the field and use the experience of other patients, our geography, our time of year, to be able to figure out what care we need. Now, what's the end of this story? Well, what does one do for viral gastroenteritis? That'd be rest and fluids. What do you do for West Nile virus? That would be rest and fluids. And what do you do for EEE? Rest, fluids, and prayer. And it turns out all three of those can be done at the Grand America. So there we go. We triaged my care using data, and we ended up with a great outcome. And so far, so good. Yay, thanks to Health Catalyst. Now, let's take another country, India. So I am running a TB clinic in northern India near Nepal. This is on the Ganges in a city called Patna. There is a personal health record culture in India. And what do I mean by that? No doctor and no hospital keeps medical records. So if you look, the patient and their families carry around their lifetime medical record, looks just like that, in a little plastic bag, and that includes their films, their ultrasounds, every aspect of their care. So the patients truly are stewards of their own data. And that's powerful. So here I am doing an evaluation, and this is a street clinic in this area. And I see a 35-year-old woman, and from a privacy perspective, don't worry, she gave me permission to talk about it. It's okay. She said, 8 months ago, I gave birth to a baby boy. Wonderful baby boy, not complicated birth, but I've had abdominal pain for the last 8 months, and I've seen doctor after doctor. No doctor is able to cure me. I've lost my life savings. I had to sell my house and my cow, and I'm still no better. So we had the advantage in this particular clinic of a $10 test called Gene Expert. And we did this on her, and we found she had abdominal tuberculosis. Now, for any of the clinicians in the room, I can guarantee you, unless you've worked in India and Pakistan, you've not seen abdominal tuberculosis. But who knew 60% of the tuberculosis in India is extrapulmonary? So imagine this as we think of their healthcare system. We develop a network of community health professionals in rural villages that have Internet of Things devices, blood pressure cuff, glucometer, pulse ox. They gather the telemetry on each patient using an Android phone. In Patna, there are no public sewage facilities, but there's the fastest 4G you have ever experienced, and every family has an Android phone, right? So you say, aha, I have my lifetime medical record, I have telemetry about me, and now with that data, we'll arrange a telemedicine visit to the right clinician to evaluate the patient and get the right follow-up. The Gates Foundation is funding this particular effort, and so far it has recruited 45,000 community health workers to help the country with this. So what you're going to see is a countrywide network of Internet of Things, analytics, all built with Android phones. And that's a great thing, yeah. Okay, Norway. Let's move on to the Nordics. I love the Nordics. So Finland, Sweden, Denmark, Norway. They have this notion. Your data should be the property of society, because if society is keeping you healthy, how dare you not share your healthcare experience with others for their benefit? Finland actually has a law that your healthcare data must be shared with society, and there is no opt-out. Imagine trying to do this in the US. This would be a little hard. And they've been able to create data aggregations for analytics, but there are some challenges. Suppose we're going to aggregate your medical data for analytics. That's straightforward. Well, what about the genome? You know, I can de-identify your problem list, your medication list, or your allergy list. Try de-identifying the genome. What if that data is lost or stolen? You can't exactly get a new genome. And so their challenge is that policy has to be made if we're going to get to precision medicine of how we're going to store and protect genomic data. And let me give you a few ideas. So those who know me, I am the second human sequenced in the Personal Genome Project. What did I have to do for that? I had to sign away my privacy for life. That was the stipulation, a 35-page consent. You agree your genome is public, your medical record is public, your Internet of Things data is public, and you're doing this as a medical altruist for the benefit of society. So I agreed to that. And have I had any negative effects personally? No. But of course, all of us have different privacy preferences. And so I just mention all this because we as a society, if we're going to develop this precision medicine approach, we'll have to think through these issues. Let me quickly contrast personalized medicine versus precision medicine. So personalized medicine. I am a 57-year-old male, and my father had hypertension, and his father had hypertension. So at age 55, I developed primary hypertension. What's the right dose of lisinopril for me? Well, on average, if you're a male in your 50s, it's 25 milligrams. Well, that's great. It's personalized to a male, 50s. It's not very precise. So it turns out I'm exquisitely sensitive to lisinopril, so I cut the tablets in half, and that works for me. And so the notion of being able to have the microbiome and the genome and what I'll call the exposome, right? I live next to a wetland filled with mosquitoes, as part of your analytics will be increasingly important. Here is how the genomic sequence has materially affected my medical care. And don't worry, it's all public. You can go download it now, so there's nothing to hide here. So it turns out when you look at my genome, it's 3 billion base pairs. You'll look at 500 mutations I carry. First thing, I carry the BRCA1 gene. I'm a male, and therefore, given that I have a Y chromosome, it's probably not so likely I'll get breast cancer. But what about my daughter? So it was critical, once I discovered that I carried this gene that leads to breast cancer, that we sequenced my daughter so that we could be assured she was not a BRCA1 carrier. So what would be the total cost to society if we were able to basically eliminate breast cancer? I mean, think of the savings of knowing who's at risk and how that's transmitted through families. So that was an important thing. Second important thing, I am at high risk for prostate cancer. Turns out I have very few cardiac risk factors, and as a vegan, I don't get any exogenous cholesterol. So yet the New England Journal says every year do a cholesterol, LDL, triglycerides, EKG, but stop doing prostate testing because over the last decade we haven't been able to reduce morbidity and mortality, so just stop doing it. But wait, I'm going to die of prostate disease and I have no cardiac risks. So based on my genome, my primary care clinician stopped all cholesterol testing and does yearly prostate testing. Again, saving money and giving me a much more precise level of care. So certainly this is a trend throughout the world as we gather these new novel data sources and use them in analytics to tailor the care so it's the right setting, the right care at the right cost. This is Dudley. Now, why do I show you Dudley? So Dudley is a Scottish Highland bull. He weighs 2,200 pounds. He lives on my farm, and his claim to fame is that he is Fidelity's bull. So if anybody has a Fidelity investment account, this is the Fidelity bull. Dudley is from Scotland, and I show you Dudley because Scotland has done something interesting. Imagine you go to seek emergency care. Maybe you're not conscious, right? Me last night. What is the doctor in the emergency department going to do to deliver the best quality care? The answer is, I'm an emergency physician. The doctor's going to guess. In Scotland, they've created a single repository for the problem lists, the medication lists, the allergies of every citizen in Scotland, and then given every emergency physician access to it. Yeah, and I know in the US, 330 million people, different problem. Certainly it's a little harder here, but think about the power of that, where every doctor that you see is going to know what is necessary to know about you. I mean, that is where we all want to get. And interoperability, you know, it's a bit like an asymptote. We get a little closer and closer and closer, but we're not quite there yet. And I look to Scotland as certainly an early mover. Australia. Australia had a great idea. And that great idea was, we're going to give every patient their lifetime medical record. Every doctor in every hospital will deposit those medical records into a single repository, and you, the patient, can download them. And what digital standard did they decide to use? PDF. Yeah. So the Eyal Oren, my friend from Google, and I were in Sydney with the health minister. And the health minister said, and you know, we're going to double the fax machines by 2022. This is not a good idea. How do you do analytics on a PDF? How do you do machine learning on a PDF? It doesn't work so well. So this is where public embarrassment works really well. So Google and I said, this is the dumbest thing ever. And the next day, Feature, sort of the New York Times equivalent in Australia, wrote this piece saying, do you know Australia is a digital dinosaur? We better move to structured data capture. And so far, Australia has chosen now to go from PDF to structured data for analytics and machine learning as a country. So that's good. So the answer is we should move fast, but not too fast, and do this in a future-proof way so that we know we'll have the data for purposes we can't even imagine. And what are some of those purposes going to be? On my farm, I have 103 Internet of Things connected devices. Now you say, wait a minute, that sounds a little crazy. Well, I have 250 animals. It's a sanctuary. They're all rescued. And from Salt Lake City on my phone, I can adjust the temperature of any stall, turn on and off every light, lock any door, and visualize the health of the animal. And of course, what people say to me is, God, why can't healthcare work like that? And so we're starting to see an explosion of Internet of Things consumer devices generating data. And that's interesting. So I have a blood pressure cuff that's Bluetooth, and I have this is, by the way, it's in FDA clearance now. This is not a commercial product available yet. It's an engineering sample. And this will cost under $100 and will do continuous ECG monitoring. So, yeah, okay, interesting. But our challenge as we get these Internet of Things devices, what do we do with the data? Who looks at it? What's normal variation? So imagine this. Suppose this says my heart rate is 20. Do you call an ambulance? Do you trust the device? I don't know. Maybe I'm running, and maybe I'm sweating, and maybe it's just not picking up so well. So we're going to have this next couple of years to figure out the data goes beyond our EHRs into the home with patient-generated data, patient-reported outcomes, and Internet of Things telemetry, figuring out where to store it, what to do with it, who's responsible. Really challenging. Now, what about AI and machine learning? And of course, you've heard in this conference about some of the novel things being done with those technologies. Let me give you just a couple of examples of what we've done. This is going to sound very prosaic to you, but it's very helpful stuff. Turns out at Harvard, it can take 8 weeks to get a specialist appointment, and yet 25% of people don't show up. Well, that's probably because it takes 8 weeks. You forgot. Could you do a machine learning model to figure out who needs to be seen, when they need to be seen, who's likely to show up and not, and much more efficiently schedule your scarce resources, your specialists? So we've worked on that and had some good success. What about ORs? How much OR time do you need? Given that there are 1 million people like you, do you need 25 minutes or an hour? Can we allocate, again, a scarce resource, OR time, not based on the fact that, oh, everyone gets a block. No, let's allocate based on comorbidities, age, gender, and patients like you. So we've done that. One of the stranger things we've done with machine learning is Google now receives our faxes and does a full optical character recognition, natural language processing, and metadata extraction from our faxes. And why do we do that? Well, it turns out we get faxed a lot of consent forms. And when you've got all this paper running around in a digital world, no one can find the consent. So this Google approach, using TensorFlow and some tools that we use from Amazon, inserts the consent into the medical record, checks the box, consent on file, good to go. And that has really helped us avoid OR cancellations. So I tell you these things because a lot of these are workflow tools to help a hospital work more efficiently, discharge more efficiently, and deliver the right care to the right patients based on millions of patients in the past. People ask me, how can we enhance innovation in an academic medical center, community hospital, and ambulatory practice? And you know what they usually tell me? The CIO is the enemy. Now, I don't know if any of you have heard this before, that, there's 200 projects in the CIO's queue, and you try to add another project, and it's like, this is going to be a challenge. So how can we think differently about this? I think you're starting to see products and services emerge in the marketplace that are app-based or cloud services that layer on top of the EHR and do agile, innovative things with the data in the EHR. And what kind of things are we going to see? Well, remember the notices of proposed rulemaking from CMS and ONC from February include a mandate that every hospital and doctor's office has an API that enables a patient to download their data to any app the patient comes knocking with. Well, that's interesting. Suddenly, what we're going to see, should this thing get to be a final rule this fall, that we're democratizing the data and putting it in the hands of the patients where then they can share it as they will. They can use it in apps as they will. They can become medical altruists. So I do envision that the EHRs, although a core transactional system, won't necessarily be the center of innovation as we go forward. APIs, you hear about that all the time, and FHIR standards are becoming ubiquitous. All our vendors have started to add these APIs and are marching through the data elements and the various types of workflows that we'll need to support with APIs. And of course, I come from Boston, where 70% of our healthcare dollars are in risk contracts and value-based purchasing today. 70%. So what does that mean? It means my incentives are totally different. An MRI is a cost, not a profit center. A hospitalization is bad. Heads and beds are not a good metric for success. So what that causes us to reflect on is, let's imagine we have a readmission problem with congestive heart failure patients. It's cheaper for us to buy them a $90 bathroom scale and via Wi-Fi monitor their daily weights looking for potential congestive heart failure exacerbations than it is for us to see them in the emergency department or hospitalize them. So as these incentives change, you're going to see healthcare systems putting these new devices, these home-based telemetry, Internet of Things devices, out at their cost, because in a value-based purchasing world, it's a much cheaper thing to do. I also hope to see telemedicine reforms. Now, this is a little bit weird, but I am the only physician at Harvard credentialed to do telemedicine across the United States for the weirdest reason. I am the nation's expert on poisonous mushrooms and plants. Every poison control center in the US consults me should there be an ingestion of a mushroom or plant. I've done 2 already today from here. So I am malpractice insured and credentialed and offer this as a telemedicine service across the country. Our telemedicine laws need a bit of reform, and the way to pay for telemedicine needs to be rethought. So again, we take the right tools and the right specialists, link together the patients, and we deliver much more cost-effective quality care that way. But here are the challenges. Okay, so imagine this watch said my heart rate was 20. No ambulance was called. I died. Does the doctor get sued for not looking at the data? But wait, this is a not FDA-approved device. Should it even have been sending data? We don't know. So there's all of these issues where we don't quite yet legally understand who is going to look at this and who's going to be responsible for it. And what data do you trust? And let me give you a silly example. So my mom, when I was 2 years old, 1964, gave me ampicillin for an earache, saw one red dot on my stomach, and said, "You are allergic to penicillin." So the metadata is, Mom, 55 years ago, red dot, allergy to penicillin. You gonna believe that? I mean, that's a little different from, nurse gave me a pill, I anaphylaxed and nearly died yesterday, right? And so figuring out as we develop this new digital world of devices and patient-generated data and apps, what data you're going to trust for what purpose will be a challenge. I think we've heard at this conference, we don't want to overwhelm more doctors with more data, right? They're already time bankrupt. And so how do we ensure what they get is actionable wisdom? So at the moment, we are not storing any of our Internet of Things data in the medical record. We're putting it to the side of the medical record and just generating alerts and reminders as an experiment to see what's going to be useful for clinicians, only telling them when there's action to be taken. Understanding normal variation across our patients as we do more and more monitoring. I mean, what if anyone who has an Apple Watch Series 4 or 5, what if you started sending lead 1 ECGs to your doctor every 5 minutes? I don't know. Do we have any idea how that normal variation in humans looks? ECGs were never designed to be done every 5 minutes. And how do we keep all this data secure and private? You probably know the virulence of cyber attacks is increasing to the point where I spend over $5 million a year just defending our networks against the every 7-second attack that's coming in. And they are very, very sophisticated. Spear phishing attacks. Click on this attachment. Click on this link. We've had to figure out how to prevent people from acting on these things that are now coming into our environment. So these are real challenges, and especially when you go outside the United States, the GDPR, General Data Protection Rules in Europe, the penalty for a privacy breach is 4% of your worldwide revenue. So that means if Apple had a privacy breach in Europe, the penalty would be 4% of $1 trillion. Yeah, how are we going to deal with that? So these are things we'll still have to work through. So some closing thoughts. I think that the app economy and cloud-hosted services surrounding the EHR is going to be the most important trend of the next 6 quarters or so. This is going to be in some ways incented by government, which APIs will now enable patients to get at their data, and more vendors will adopt these API approaches. And although government will be an accelerator, it will be the private sector that creates the real innovation. And certainly when I look at what Health Catalyst is doing with its various services and apps, it's very much aligned with this trend. We do not need to wait for flying cars. Right? We have the technology tools we need today, the cloud and FHIR. We are seeing these API standards emerge to the point where they're, again, good enough and complete enough. One that I'm working on currently is the cancer API standard for the country. This is under the Cancer Moonshot Project. It's called the Minimal Clinical Oncology Dataset for Exchange, or MCODE. And in early October, we're going to have a major conference in McLean, Virginia, announcing this standard to the country. So we're going to have a much more fluid set of data exchanges. And final thought, we love our EHR vendors. They're good, but the EHR is just a transactional system to gather data. It is not going to provide us the analytics, the usability, and the next generation of healthcare workflow we all want. So, hey, I guess what this means to Health Catalyst, the world is your oyster. So, hey, thanks very much, and I do want to take some questions and answers. Here we go. Okay. And see, I didn't even have a syncopal episode. They were worried.
We were worried. We had someone backstage.
Yeah.
The first question you started to answer at the very end, so maybe I'll change it a little bit. The question was, how can we own our lifetime record online and in the US? And maybe I'll just change it a little bit, is how long do you think it will be before patients own that data?
Right, so part of this is figuring out what is your lifetime medical record. So the Senate Health Committee, lovely policy-making group, and I were chatting about what is interoperability. They said, it's every data element in your lifetime medical record exchanged with every stakeholder for every purpose in real time for free. Well, if that's your definition, it will take a bit. But if what you decide in a Pareto analysis that the key data elements are your problem list, your medication list, allergies, labs, RADs, care team, care plan, that's in the current notice of proposed rulemaking as an API requirement, enumerating FHIR and the Argonaut standard as the way to do that. So, right, in theory, you'll see the EHR vendors offering this in their current releases. I think an interesting challenge will be operationalizing it. And here's what I mean. So my mom is approaching 80. And I said, do you know there's a FHIR-enabled API and you can get all your data? And she, of course, said, I'm not sure why I'd want that, but if you did it for me, that'd be great. Right? And so we don't yet quite have the delegation service that would enable a patient to say, I'm going to give this to a family member, or maybe a third-party care navigator to help me with it and that kind of thing. So we'll have to work through some of those issues of authentication and authorization. But the FHIR standards, they're being built into the EHRs, and the mandate to do it are happening now.
So, but you've been around healthcare. Do you think where it becomes mainstream, is that a 5-year thing, a 10-year thing, a 2-year thing? How long do you think it'll take us?
Well, of course, you always have a hard time predicting the speed of innovation. But again, I don't endorse any product or service or company, but look for a moment what Apple did with HealthKit, right? So basically they said, on your phone is a container, and it can today connect to any Epic or Cerner site. Like, oh, okay. Well, suddenly I get people meeting me on the street saying, yeah, here's my lifetime record. And I just pushed a button and got it, right? So the tools are getting there. So I would tend to say this is not a 10-year thing. It's early adopters in the next 6 quarters and 5 years for mainstream. And some of this will be pushed by consumers. I mean, my 27-year-old daughter expects a digital healthcare system. And so she would change doctors and hospitals if she had a digitally enabled, downloadable experience.
Yeah, that makes sense. We had a lot of other questions about blockchain, just giving you...
I knew there'd be a blockchain
about
question.
Blockchain.
Yeah, see, there's always one. So I'm editor-in-chief of Blockchain in Healthcare, and why do I edit that journal? To tell people what blockchain won't do. Right? So blockchain is a decentralized ledger that you write to and can never erase. Is it an analytic tool? No. Can you do an AI machine learning application on blockchain? No. Is it really replacing a database? No. It's slow, it's cumbersome, it's unscalable. But where is it useful? So imagine this. Suppose that I see you in clinic, I write a note, some bad outcome happens. A plaintiff attorney says, I want the medical record. I hand over the medical record, and the plaintiff attorney says, oh no, this has been altered. This has been changed, deleted. So what if, as we signed our notes, a hash of the note went into the blockchain, in effect proving that over years the note was not altered or changed? I mean, blockchain is good for that kind of thing. Don't store the note itself, but a hash showing that this mathematical transformation, if done in the past and it's the same today, really does demonstrate the note wasn't changed. Or how about this? The Synaptic Network Alliance, which is a group of insurers, has said credentialing and provider directories are hard problems. Right? I have hundreds of insurance companies that I have to send credentialing and provider directory data to. What if you put it on the blockchain and everyone just trusted it? And that if you needed to look up, did I go to UCSF Medical School, and did I have a residency, and am I board certified? It's all on chain. So that'll be interesting. That's probably a reasonable application of blockchain. And probably the last interesting application of blockchain would be consent. Now, here's a problem. We have 50 different states with 50 different consents, right? Alas, if you want to send data from New Hampshire to Massachusetts, the consents are totally different. So what if on the blockchain we enumerated your preferences? I agree to share all my data for these purposes, and everyone who wants to use your data would just go to the blockchain, look at your consent preferences, and respect those preferences. So those are the kind of things you should look at. But remember, it is not a database, it is not an analytic tool, it is not an EHR data storage container.
Got it. I want to interject a personal question. It wasn't asked here.
Oh, go ahead.
When you and I talked, you said you had the best job in the world because you get to do innovative stuff with your team. So what's like an example of the cool innovative stuff that you're doing now with your team at Beth Israel?
Sure. So let me give you just 2 quick examples. So do you know that in our college-age population, there's a significant depression and anxiety problem? Do you know that we can, with amazing sensitivity and specificity, diagnose it from the way you use your phone? Right? I actually don't need you to see a behavioral health expert. I can just look at your patterns of use. I mean, think about how many times do you pick up your phone every day? And how many times do you email or do you tweet? How many times do you go to social media? What is the change over time in your use of this thing? And we're able to now offer, in effect, a digital psychiatry clinic looking at telemetry from your phone. We can also look for medication compliance that way. So that's an exciting project. Opioids. Now, I don't know, in Utah you have an opioid problem?
Yes.
Okay, yeah, well, Massachusetts, ground zero.
Okay.
Now, why do we have such an opioid problem? I went to medical school in the 1980s. And when my chief resident said, go write for some hydrocodone or oxycodone or whatever, I said, how many? And the chief resident said, 20, 30, just that's what we always do, right? So we did a study, and my team collected the pill bottles from 7,500 post-op patients and counted the number of pills. And cut to the chase. What is the average number of narcotics required in the most common procedure, a cholecystectomy, a gallbladder removal? The answer, 2. Right? And so the work that's being done is, can we build machine learning models that say, for the patient in front of you who has this procedure and this history, how many narcotics do they really need? Maybe the answer is 0, we hope. But it's certainly not 20 or 30. It's going to be 3. And that's the way that we can start to get people away from their even introduction to narcotics. That's an exciting project.
Wow, that sounds interesting. Last question. People mentioned the Estonian system as being a really digital system. Are you familiar with that at all?
Absolutely.
Can you tell us what you think about that system, and is there anything we can learn from them?
Well, sure. So I'm Latvian, by the way. So this is the Baltic states there, and small countries, very homogeneous population. Politics are not so difficult there. So they have such things as common registries of who the patients are, common registries of who the doctors are, common mechanisms of doing e-commerce, and blockchain-based databases. Again, you have to be a little careful. They're really used more for data integrity than so much actual data transactions. So what the problem that we have in the U.S., do you have a healthcare identifier? Do you have 12 healthcare identifiers?
I don't
How
know
do we even know who you are?
My wife is the one that knows that. I don't know anything.
Right. And so in the U.S., we not only don't have a national healthcare identifier, we don't even have a nationwide patient matching strategy, right? So we use name, gender, date of birth. Oh, maybe we'll use voter registration records. Oh, maybe we'll use biometrics. Everybody does it differently. Well, Estonia just solved the problem. Right? So one of the things you love about a small country is when they decide they're going to create one database for person identity, doctor identity, one database that is going to follow you across your entire healthcare experience. That's powerful. I guess the last thing to say is, how many PACS systems does Scotland have? 1. Right? When you're a small country, just put every image in one place and every doctor could see it. So there are some interesting advantages of being small and agile.
Well, very good. We're out of time, so please join me in thanking Dr. John Halamka.
Thank you. Thanks so much. Absolutely.